Well, hello everybody, and welcome to this exciting forum on COVID capitalism and the fight for healthcare justice and societal transformation. My name is Ollie Fine, and I am the chair of the board of the New York Metro chapter of Physicians for a National Health Program. Before we get started, let me share some Zoom logistical details with you. In this webinar format, all attendees are muted. If you would like to share a comment or ask a question, please use the chat or Q&A functions. We will do our best to get to as many questions as possible. After each speaker, there will be an opportunity to ask the panelists questions. We ask that you type those into the Q&A function. Now, I would like to introduce you to our first moderator for the evening, Dr. Martha Livingston. Dr. Livingston is the chair of the Department of Public Health at SUNY Old Westbury and is vice chair of our New York Metro chapter for a National Health Program. Take it away, Martha.
Hey, thanks, Ollie. Thanks very much. And welcome, everybody. This forum comes, we feel, at an absolutely critical moment in our country. You know, we say this a lot, right? Unprecedented, watershed moment and so forth, but this really feels that way. It feels as though so much is in motion that it's really critical for us as PNHP and part of a broader social and political movement for justice to maximize what we can accomplish with our limited political and social resources to make this to really have the most impact possible. We really feel as though this is a country and world-changing moment, and we want to understand as best we can how to make that happen. We know that PNHP is a single-issue organization, but we also understand that Medicare for All doesn't come in a political vacuum. The late, great Tony Mazzocchi of the Labor Party and oil, chemical, and atomic workers used to say that Medicare for All opened a window on the social wage. That is to say, if we can have healthcare, why can't we have all the other things that the 99% need to have a just and decent kind of life in the richest and most economically unequal country in the world? So that's our task for tonight, to open that conversation. And I frankly could think of nobody better to start us in that conversation than Dr. Adolph Reed. I've been reading his work for years, and when I want to have just the most cogent kind of analysis of what's going on politically, he's one of the people whose work I turn to. So it's actually my great honor to introduce Adolph Reed Jr., Ph.D., Professor Emeritus of Political Science at the University of Pennsylvania, who specializes in race, class, and American politics, and has been an organizer for Medicare for All South Carolina. He recently wrote an essay, fascinating, called Disparity Ideology, Coronavirus, and the Danger of the Return of Racial Medicine. And another interesting article, recent article of his, is The Push for Racialist Justice Beyond Race Alone. He also co-authored a very recent piece called Racial Health Disparities in COVID-19, Caution and Context. So without further ado, I welcome on behalf of PNHP New York Metro, Dr. Adolph Reed Jr.
Hi, Martha. Thank you very much for that intro. It's a mutual admiration society that we have going. I feel the same way about you. And I'm really honored and quite happy to have been asked, and look forward to being part of this conversation tonight. I guess, and I've been connected to PNHP for a long time. Quentin Young was my doctor and my friend in Chicago. I guess I should begin by saying that I'm undoubtedly the least likely person in the discussion to have a reasonable speculation about when we're going to come out, the other side of the pandemic. I can say, though, that whenever that is, we'll have the same difficulties we had before the pandemic, but worse. I don't need to give you a litany. Many millions more people will be without access to healthcare than before. Many millions more will be without jobs and income, will experience either homelessness or housing insecurity, will go hungry, and will be vulnerable to other diseases associated with economic insecurity and inadequate access to healthcare. I think it's important for us to keep that reality in mind, especially at this moment, because many in the chattering classes and others who are enthralled to the 24-hour news cycle contend that the pandemic and more recently the protests sparked by Derek Chauvin's video murder of George Floyd have shifted public focus away from issues like Medicare for all and other policies that would advance a public good-oriented framework for government. Police reform, of course, is an urgent issue, and it's important that the national and international uproar prompted by the accumulation of shocking evidence of police violence has set in motion forces that promise finally to succeed on that front, although the proof of the pudding is still going to be in the eating. But in addition to that intervention, we are again going to face the same uphill struggle for social justice, perhaps even more steeply so, as we did before the pandemic. So for that reason, I think it's helpful to take stock of where we were at the beginning or at that moment. Maybe Bernie Sanders supporters, or rather many Bernie Sanders supporters, had just come off the emotional equivalent of a whiplash experience. First was the great high of the campaign's strong victory in Nevada, where rank and file members of Culinary Workers Local 226, indicating the strength of their support for Medicare for all in particular, defied a hard sell, to put it mildly, by their elected leadership for Biden and turned out heavily for Sanders. Then came the DNC blitzkrieg of South Carolina and Super Tuesday that effectively pulled the rug out from under the Sanders campaign. I remember sitting in a bar with my comrades, as well as a bunch of former students from DSA Philadelphia in Charleston, watching the returns come in on primary night, and it was not fun. But that experience gave rise, of course, to a lot of second guessing, finger pointing, and the like. But the reality is that it was always a very long shot that Bernie would win the nomination. And I think that's kind of sort of an anchoring point for us in talking about the political future, for now, I think. The corporate Dems made clear practically from the very first that they weren't going to let that happen. And they even said so explicitly after he won the Nevada primary. But so what are the lessons that we can take from that campaign? From the perspective that it was always a long shot, I think the campaign was successful and was quite successful because, as I said, it was always an initiative that operated on two planes, and two planes that often aren't compatible. It was clearly an electoral campaign that was driven by the logic of election campaigns. And I always think of electoral logic as being inexorable in the way that a friend of mine in college used to say about acid. He said, the thing about taking acid is that once you buy the ticket, you got to take the ride. And an electoral campaign is like that. There's a certain logic that leads toward aggregating as many votes as possible on whatever terms as possible. And that's just the way it is, even if you're running, like a Socialist Workers' Party protest campaign or something. But it was also, the Sanders campaign was also an effort to kickstart a movement building organizing campaign. And that operates off a different logic, right? A logic of building having different kind of contact, seeking different kind of contact with people, seeking contact with different people, and different objectives and pace even, right? Different approach. And the big news from the campaign is that the big winner in almost every primary was Medicare for all. Even in states that Bernie lost badly, for example, South Carolina, a majority of voters indicated their support for Medicare for all. In the Debs Jones Douglas Institute's Medicare for All South Carolina campaign, for example, more than 18,000 mainly Black South Carolinians signed pledge cards indicating their desire to vote only for candidates who support Medicare for all. Now, there are reasons for the apparent disjunction in states like South Carolina and elsewhere between expressed support for Medicare for all and actual voting practice. And that have to do with the nature of electoral politics and what people have been left to construe as its limits for probably 40 years or more. And we can maybe discuss some of that in the Q&A or at some point. But this is the foundation, I think, for the popular movement building project. And that's where I think that our focus needs to be for the next several years. I think there are a couple of takeaways from this most recent electoral season. One is that, as I said earlier, the DNC or the corporate democratic forces or the bipartisan neoliberal governing regime or whatever we want to call it, isn't prepared to open the door to Medicare for all. It's not prepared to open the door to the expanded social wage policies that Tony Mazzocchi talked about, as Martha mentioned, in our intro, and that we also fought for in the Labor Party and are fighting for today. And what that means is that we need something beyond politics as familiar. I don't want to say politics as usual, but familiar approaches to left or progressive or insurgent politics have focused for most of my adult lifetime on a presumption that there are liberal Democrats of goodwill who exist in sufficient abundance in Congress or on city councils or elsewhere, that if we just find the right way of packaging what we're trying to get across, get the right panoply of interest group support behind it, then it'll be possible for us to push through winning legislation. I think that's become more and more difficult, and I think the fact that that's become more and more difficult shows up in and is indeed one of the reasons that voters tend less and less to look to the electoral realm as the place where they go to fulfill their political dreams and ambitions, which is one of the reasons that people disconnected voting for Sanders from supporting Sanders' program. I think that I think this is the point for making what I think is a really significant distinction for us to ruminate on as we consider our political work going forward. But drawing on my old friend and comrade Jane McAlevey and her most recent book, she cranks them out pretty quickly, so there may be another one coming. No shortcuts. I want to stress the crucial distinction between mobilizing and organizing. Mobilizing, as I put it to a student a few days ago, appeals to common sense, and organizing seeks to change common sense, like to alter the dominant terms of debate. Most of what we've been doing in most of my adult lifetime has been trying to make change through mobilizing. And the nature, the depth and intensity of neoliberal hegemony are so great at this point that I really don't think there's a way forward for us unless that's apart from building a deep and broad coalition around a different kind of political agenda, right? And what that means is we need to go into mobilizing, or rather into organizing mode. And that doesn't mean that everybody's got to go out knocking on doors, but it does mean that groups that have a comparative advantage for mobilizing interested actors, and I'd say that PNHP is certainly one of such groups, a lot of others too, do what they're doing and have been doing well. And I don't want to say but, and so we should be doing it in concert with like a movement building project. So, I mean, here's one illustration. I'm watching my time because the deadliest thing to do is like give a professor time without a hook. But the idea of just transition, for instance, right? We in the Labor Party, and now in Debs Jones Douglas and I mean, the Medicare for All campaign, Medicare for All South Carolina campaign, are committed, right, to are convinced, right, share a conviction that we don't have a chance of winning anything that we would want to recognize as Medicare for All unless we can assure working people about the transition impact, right? And the transition impact is broad, of course. I mean, everybody who's involved in this meeting knows, has a rough idea of the magnitude of what displacement would be like in transition from a for-profit healthcare system to a Medicare for All system. And it's probably even greater than we might imagine that it is, or than a novice like I am would imagine that it is. But the only way we're going to win this, and I think that this is like another lesson to take from the Sanders campaign, the only way we're going to win is to build a broad, deep, popular movement that, as Martha also said, sees Medicare for All as an element within a broader struggle for what we've been calling lately a public good oriented approach to government. And I'll say this, and I'll shut up in a second, that when we were working in South Carolina, one of the things that we found, and we, like our campaign was a grassroots campaign. I mean, it was, we've been working down there in one capacity or another, in one campaign or another for more than 20 years. And we made connections in communities with people who are organic leaders in those communities. But one of the things that we found was that once people started talking about Medicare for All and like developed a sense of what it is and that it can be won and that it would be simple, apart from the technocratic stuff that the economists like to have fun over. I almost said gratify themselves over, but I won't. But anyway, but once they begin to think about that, people tended to get excited and think about, without even being prompted, stuff like, well, why can't public post-secondary education be free, right? And just on from there, right? I mean, adequate housing. So we're gonna, hate to say it, right? But it really does look like the only way that we're gonna win Medicare for All, right, is as part of winning a broader struggle for social transformation in the US, altering federal spending priorities and policymaking priorities, but a different kind of governing vision that's, crafted, as we used to say in the Labor Party, by and in the interest of the vast majority of people who live in the country, those who are expected to work for a living. Now, but what that means also, it sounds like the project, I just made the project seem a lot more daunting. But the reality is, there are ways we can think about this, right? Like if we start thinking about winning a significant reform like Medicare for All, that the for-profit healthcare industry will fight tooth and nail against, because it takes the profit medicine or the profit motive out of medicine, right? Then we open up a discussion about other decommodified public goods. And I think ultimately the only way we're going to win Medicare for all is as part of the broader struggle for that other kind of vision that's grounded concretely in practical, issues like free public higher ed, decommodified housing, et cetera, et cetera. So, let me stop there. I think I've taken my time.
There's a couple of questions that really grow straight out of what you've talked about. You haven't specifically addressed kind of the last couple of months. This talk was a little more BC than AC, if you follow my drift.
Right.
One question that really springs to mind is, what is your perspective on the powerful new Poor People's Campaign? And how do you see that as being playing a role in building this broader social movement and actually organizing versus mobilizing?
Right. Well, I've had some peripheral connections with the Poor People's Campaign. I think we all tend to be premature in our assessments of initiatives of that sort, right? There's I was just joking with a friend of mine, this morning, saying that, we should have like a file category for, or a genus on a taxonomy called this time it will happen, right? There's a lot of emotion and energy around the Poor People's Campaign. I'm Reverend Barbara and Liz Theo Harris, who I've known for a long time, are good, talented, energetic people. I think that the most important objective for us is to find ways to start talking to people who don't already agree with us. And that's the most important work that there is for us to do. And one of the ways that mobilizing and organizing, and I don't want to fetishize those two words either, but one of the ways that they get conflated is that if you're mainly talking to the choir, then you don't get much but validation, and it's harder to make a distinction as to when you're talking to people who already agree with you and when you're trying to win people over. So I guess in short, what I'd say about the Poor People's Campaign is, this is another Tony Mazzachism, but we're all throwing strands of spaghetti up against the wall, and we'll see what sticks.
Mm-hmm. Mm-hmm. Yeah, vis-a-vis the last comment you made, my friend Mike Zweig, who I think you know also, Michael Zweig, says if you're not doing politics with people you can't stand, you're not doing politics.
Great. Yeah, absolutely.
A question from an old PNHP comrade is, how do you see the Medicare for All movement being different now from how it was before both COVID and the Black Lives Matter protests?
Right. Well, in one sense, COVID should make it easier for us, right? I've been saying a lot lately that I can't remember when was the last time I heard Joe Biden going on about how much people love their employer-provided health insurance. And it's clear that the magnitude of the problem is clearer and greater now than it ever has been. The inadequacies of the current system right? Even hospitals, for God's sake, right? Well, I mean, every day you see more illustration of the corrosiveness of the profit motive in the delivery of healthcare. I mean, nursing homes, for Christ's sake. So in that sense, in principle, it should be easier for us, right? We have to say less once we're able to get out and connect with people again, right? With respect to the other, and I mean, for that reason, like we've kind of been chomping at the bit. I mean, waiting, I mean, hoping for, trying to figure out how to keep moving things forward, like in South Carolina in particular, but also elsewhere. With respect to the Black Lives Matter stuff, I think, to be honest, I think we're also going to wait or need to wait to see how that plays out, right? I mean, there's no question that the anger and the indignation are righteous and justified. There's no question that the bodies in the street are impressive. But, you know, years ago, I was talking to a friend of mine in Chicago who told me that he had recently gone to a big event, a big conference of organizers in the Midwest that was sponsored by the Midwest Academy. And they filled up the United Center where the Bulls and the Blackhawks play. And he said he was there and he looked around and he saw like 25,000 people in the United Center. And he thought, wow, this is really something, like we've got something here. Mm-hmm. And he said, but you know, then I thought about it and I remember it. Well, the Bulls and the Blackhawks do that 41 times a year each, not counting the playoffs, right? So we need to maintain some perspective, right, about stuff. And you know, young people are exuberant and that's great, but we need to, you know, just see how this is going to play out with respect to police reform, which is the initial impetus. I'm sure a lot of you guys in the sound of my voice don't exactly know what to make of the almost $2 billion, it's probably over $2 billion in corporate money that's been pumped into or around this, that's been flashed around this. I assume I'm not the only one, and I'll finger Ali because I don't know anybody else well enough to do this to him, but who is old enough to remember the war on poverty and how that played out. So, I mean, but again, like police violence is not the only issue that Black Americans are concerned about. And it's not, again, it's not the singular issue that most Black Americans wake up being concerned about every day. And most working Black people are like most other working people, that the issues that you carry around, and I'm not at all trying to make light of the anxiety about what happens when one kid is out in the street. I mean, my son got swept up by a cop, black cop, with a jerry curl also in New Haven, Connecticut when he was 15. And when I got over blowing up at the cop, I said to him, well, I guess you just had your bar mitzvah. But because I had the same experience myself, I'm not naive about that. I'm not trying to deny it. But the point is that most people, most of the time, are more concerned with stuff like if they don't have a job, finding one, if they have one that's decent, keeping it, paying a rent, paying a mortgage, being able to get sick, right? Sending your kids to school, et cetera, et cetera, et cetera. And in that sense, right, those issues are the issues that most Black Americans are concerned about most of the time. And I would just add, since, I'm not trying to be provocative, but I remember in the early to mid 80s when I was teaching at Yale, and a particular kind of race-conscious politics became prominent among my colleagues in African American studies or my Black colleagues or whatever. And I recall having a number of conversations about, you know, black issues, in which I would mention sort of jobs and housing and income and social wage policy. And the response that I got from my colleagues was, well, Black people aren't concerned just about material things, right? About material issues. And I thought, yeah, well, I can see why you say that, because you've got a good job that pays well, you've got, you know, health insurance, et cetera, et cetera, et cetera. So I'll just say this once and let it go. But the notion that a political agenda that's focused on advancing the, securing the material position of working people is somehow not a pertinent issue to Black people is not a racial politics, it's a class politics. And it's a politics of a particular class perspective among Black Americans. So I guess you kind of asked, the question was maybe a little bit what time it is, and I gave a bit of how to make a watch, but you know, it's just what it is.
I love it. You're reminding me of the idea that, you know, once folks got the opportunity to sit down at the lunch counter, then they needed to pay attention to whether they could afford the hamburger.
Right, exactly.
So I think at this point, maybe we should move on to Steffie's presentation, have time for a little, we'll have time for Steffie focused Q&A, and then we'll bring it all back together. And we'll have an opportunity for everybody to ask about both issues. So I'm going to introduce Steffie's introducer, and that is my fellow PNHP New York Metro board member, Will Ford. Will is a third-year med student at Weill Cornell Medical College. He's leader of Weill Cornell's chapter of Students for a National Health Program, as well as a student board member of our PNHP New York Metro chapter. Will, take it away.
Thanks so much, Martha, for that introduction. And thank you again to everyone who's tuning in tonight for our forum. We're really glad that you could join us for this exciting event. So I'm delighted to introduce our next speaker, Dr. Steffie Woolhandler. Dr. Woolhandler is a co-founder of PNHP and a practicing primary care physician. She's also a distinguished professor of public health and health policy at CUNY School of Public Health at Hunter College. She's an adjunct clinical professor at Albert Einstein College of Medicine and a lecturer in medicine at Harvard Medical School. She's the co-author or author of many relevant peer-reviewed research articles on single-payer healthcare. And most recently, she's published articles co-authored with PNHP co-founder Dr. David Himmelstein and PNHP president Dr. Adam Gaffney about the dangers of our privatized multi-payer health insurance regime in the intersecting crises of the COVID-19 pandemic and its resulting economic downturn. Dr. Woolhandler, thank you so much for joining us tonight.
Hey, well, it's my pleasure. I don't have any financial conflicts of interest. I do, I guess, have other conflicts. I actually was an unpaid campaign advisor for the Sanders campaign, as well as having a close professional relationship with Elizabeth Warren. Okay, let's see. I can't get my screen to advance here, so maybe the PNHP folks are going to have to do that for me. You want to try to advance the slide for me, please? Doesn't advance, sorry.
Are you sharing from your computer?
I am screen, it says you are screen sharing, and it won't advance, the computer won't advance the slides. So I'm stuck.
If you could just do us a favor and stop sharing for a second, then one of us can pull it up. Thanks, Steffie. Sorry about that.
Okay.
Will, do you want to?
Yes, yeah, I can definitely pull it up.
Okay, I know that slows us down, but I don't know why it wasn't working. Okay. Sorry to waste people's time with their technical thing. We did check ahead of time, and this all worked, so not sure what to say about that.
The vagaries of technology.
Yeah.
Here we go. Can everyone see that?
We can see it.
Okay, we're looking at, Now, did I just advance it or not?
No, I've got control.
Okay.
Just let me know when you want me to go ahead.
All right.
And I'll do it.
Okay, sure. Let's go to the first slide. Besides my conflict of interest, there's me and conflict of interest. So, okay. Okay, I'm viewing Will Ford's screen, so that sounds right. Okay, probably most people on the call are well aware of the very high death rates from COVID-19 in the United States, and that these vastly exceed death rates in other countries. Next. You're probably also aware that the pandemic has been much more serious and lethal toward Black and Latinx people. These are the numbers for New York City as of 3 days ago, but this is being replicated around the country. Next. Okay, now why was the United States so vulnerable to COVID-19? I'm going to talk about 4 different reasons. There's the fact that the health status of the American people has been deteriorating since about 1980, but particularly over the last few years. We have a weakened public health capacity. We have a crumbling and racist social safety net. And we have a wasteful and I would say structurally racist healthcare system that prioritizes profitability over needs and discriminates against all poor people, but particularly poor people of color. Next. So deteriorating health status. Here I've graphed life expectancy in the United States and several other nations, and you'll see through the 60s and 80s, the US was pretty much middle of the pack in red, but middle of the pack. But since about 1980, the United States has been falling off the curve. And actually, in 3 of the last 4 years, life expectancy actually fell, and almost certainly life expectancy is going to fall again in 2020. Next. So on top of this poor underlying health status, we have the problem of public health being relatively defunded. Public health has fallen as a share of total health spending and is now only is under 2.5% of total health spending versus about 6.2% in Canada. So we're not getting the health dollars to public health. Next slide. Now Trump has further weakened public health in several ways. He's demoralized the public health workforce. First of all, there was a hiring freeze in 2017, during which there were 700 positions at the CDC that were left vacant. In 1918, Trump abolished the Global Health Security Team to the National Security Panel, effectively demoting pandemic preparedness experts. 1,600 government scientists have left positions since Trump came into office through this demoralization, and many key science positions, including the OSHA administrator, have been left vacant. Recently, Trump defunded the WHO, which is responsible for global surveillance and risk mitigation, which we're going to need if we're ever going to get out of this pandemic. And then obviously 2 days ago, he announced that he told his people to do less testing to make his numbers look better. So a lot of actual weakening of the system, but also demoralization of folks who were tasked with defending us against pandemics. Next slide. Okay, so the frontline healthcare workforce, that is the people at local health departments who do contact tracing, who keep track of the rates of disease. In some cases, they do lab testing. The frontline public health workforce has declined by 20% over the past decade and a half. Next. And of course, I do believe, like Richard Horton, the editor of The Lancet, the defunding of the World Health Organization is actually a crime against humanity, likely to harm health of people in the United States and around the globe. Next. But what about the social safety net? what are the issues there? And again, I think many in the room are familiar with this, but in New York City, we have 400,000 children who live in poverty, and there's 114,000 students in New York City public schools who were homeless in the last year. So profound impoverishment of part of our population. Next. And of course, housing has remained a major issue, and its social distancing is impossible in homeless shelters, but in fact, extremely difficult in the crowded circumstances in which many poor New Yorkers and poor people in the United States generally are forced to live. Next. And within our prison and jail system, which houses about 2.2 million Americans, again, social distancing and protection from contagion is virtually impossible. And just to read you the headline, these are folks at Rikers who are going out to dig mass graves for New York City coronavirus victims. Next slide. Okay, so what about the failing healthcare system? Next, I think people are more familiar with that in this group, but the number of uninsured has almost certainly shot up since the beginning of the COVID epidemic. There's likely about 43 million uninsured Americans as of the end of June. Things may get worse, frankly, when the special stimulus money runs out at the end of July. Next slide. One group has been relatively immune to the problems in the economy, and that's large health insurers. They're doing just fine in the face of COVID-19, in the face of massive illness, and in the face of millions of Americans losing their job-related health insurance. In fact, the industry, according to our estimates, says the Vice President of Moody's could have a net benefit. Next slide. If we look at the first quarter profits, so these include the month of March in 2020. In fact, first quarter profits for the major health insurers were actually up. Next slide. And if we look at the what the market thinks is going on with health insurance stocks are near an all-time high. So apparently Wall Street does think their future is rosy, and the green line's the Standard & Poor, which is not doing nearly so well. Next slide. Now, let's talk a little about what COVID has done to doctors and hospitals, nursing homes, other aspects of the actual delivery system. Next slide. Many doctors' offices are simply can't make payroll, having to be shuttered, and it turns out to stay afloat in the pandemic. Many doctors' offices have turned to GoFundMe campaigns just to pay their staff and keep their doors open. Next slide. And if we look at employment between March and May, so up to the middle of last month, there were huge losses in ambulatory services, including doctors' offices, large losses in home care, nursing homes, and even within the hospital sector, there has been a 3% decrease in total employment as people get laid off and demand has shrunken. However, health insurers seem to be doing just fine in terms of their employment. So we have seen health insurers take this opportunity to play a larger and larger role and make more and more in the way of profits in the face of a pandemic. Next slide. Meanwhile, many of our health workers are living in poverty. A large percentage of hospital, nursing home, and particularly home care workers were living in poverty even before the COVID pandemic. Next slide. And next slide. And even before the pandemic, many of these frontline healthcare workers were themselves uninsured, including about 15% of all home care workers in this country. Next slide. Okay, now what's going on with the healthcare system? How can we get in the middle of the pandemic, people losing their jobs in healthcare, health insurance companies making out like bandits? And I want to just go back to this book by Regina Hertzslinger called Market-Driven Healthcare. And for those of you not in the field, she popularized the idea that hospitals would turn into focused factories that would pursue profitable service lines one by one. And while the book was a somewhat exaggerated view of where we were going, it does actually give us some insight into what's wrong with the healthcare system and why it's doing such a terrible job fighting COVID-19. Next slide. For instance, elective surgeries, one of these profitable service lines that Hertzlinger recommended, are the cornerstone of our hospital system's operating model. And the negative impact due to the cancellation of these procedures cannot be overstated. So this is actually a quote from the owner of the largest for-profit hospital firm, which at the time was laying off medical assistants who were involved in COVID-19 testing. So at the same time that demand for care, for sick care was increasing, the hospitals were seeing their business model shrink and collapse. Next slide. And a consequence of that is that hospitals that don't provide tons of elective surgeries, that actually serve communities in need, find themselves in a poor financial position. And this is actually data purchased, like this data released within the last week on the total value of buildings equipment at U.S. hospitals, the total value of capital assets, if you will, per bed day at U.S. hospitals. And hospitals, total assets are in green, but hospitals that serve lots of Black patients, lots of Latinx patients, have lower assets to lower value buildings and equipment to actually provide care to their patients compared to hospitals that serve mostly white patients. Next slide. And of course, these Black and Latinx serving hospitals are able to offer fewer high-tech services. These are odds ratios that a service will be offered at a Black or Latinx serving hospital relative to what is offered at a white serving hospital in this country. So we have starved many of our hospitals, particularly hospitals that pay for poor people and for people of color. Next slide. Of course, as many of you know, we've seen tremendous bureaucratization and growth of administrators within the healthcare system, designing these focused factory models, collecting from hundreds of or even thousands of insurance plans. Next slide. And at Duke Medical Center, for instance, they have fewer than 1,000 beds, and yet they have 1,600 billing clerks, jobs that really should be, and personnel who really should be retrained for patient care. And perhaps we can talk about a just transition at the end of this, but if we are going to expand primary care, mental health care, substance abuse care, if we're going to upgrade the hospitals that are used by people of color, we're going to have lots of new jobs within the healthcare system so we can retrain some of these people displaced as we shrink the administrative side of healthcare and actually use those people to enhance care for the population. Next. Overall administrative costs in the US versus Canada are obviously massive, but in the setting, these are on a per capita basis. We're spending about $3,000 more per capita per year in healthcare administration. That's relative to Canada, and that's $3,000 that's not actually available for patient care. Next slide. So what has happened in terms of COVID-19? Well, Congress has done some things. They've established free coronavirus testing. Some insurers, but not all, will waive your deductibles and co-payments for in-network treatment. But if you're out of network, you're out of luck. There have been modest extra federal Medicaid dollars to state through the Medicaid match. There has been extra Medicare dollars to hospitals, but the way they were targeted is they went to the most profitable hospitals primarily. Congress has mandated 2 weeks of sick pay, but big employers, that means any employer with more than 499 employees, is exempt, okay? There's been a $600 boost to unemployment checks, which has been extremely helpful to people, extremely helpful, and is part of the reason why the standard of living of many working class Americans has not totally collapsed. However, this $600 boost to unemployment checks expires at the end of July. And I think we will be seeing lots of economic collapse, evictions, and the like. There's been massive bailout funds that went predominantly to corporations, somewhat less to small businesses, and about $1,200 per worker stimulus checks to lower paid people. So these checks, Trump insisted that he had to sign the checks himself. And next slide. And of course, sometimes there's confusion because he has been responsible for so many deaths and death certificates, and perhaps his signature needs to be on those as well. Okay, I'm done. So let me unscreen. Maybe you need to unscreen share there, Will.
Yep, that's on me.
Yeah.
All right. Thank you so much, Dr. Woolhandler, for that great and really kind of gripping and frankly frightening presentation on some of the effects of this pandemic on patients who are most vulnerable. It reminds me of Julian Tudor Hart's inverse care law that says that the communities that are most in need of investment in healthcare are often the least likely to get it. So I'm a little bit behind on checking questions because I was sharing the screen, but I have a couple that I had sort of thought of to kick us off here. And so, one of the things in this pandemic that's occurred is, this rapid, increase in the amount of information that we know day by day about COVID-19. And it seems like, we're going to have patients recovering from COVID-19 for, quite a while and experiencing significant long-term effects from their illness. But as you pointed out in your presentation, many of these measures that have been introduced by federal and state legislatures to combat the pandemic and the economic consequences are sort of designed as short-term goals. And I was wondering if you could comment on that and what you see might be some of the consequences or what we might see in the coming months.
All right. Well, first, so the technical issue about long-term health consequences, certainly people who suffered strokes or heart attacks or kidney failure may have long-term consequences. Many people who had severe ARDS, severe respiratory failure, do seem like they currently have some lung abnormalities, but in other viral illnesses that induce ARDS, most of the abnormalities clear up over 6 months to a year. So we're still hopeful that the lung problems will clear up over time. We don't know that because we've never seen COVID-19 before, but I think we're hopeful about that. I'm pretty clear that the economic impacts are going to be with us for a while. We're not through the first wave of the epidemic. In fact, we're still in the first wave. We might get a second wave. It might become endemic unless we can come up with a vaccine. So the negative effects of COVID-19 are really likely to be with us for quite a while.
Right, and those those effects are both on the health of individuals and then also on sort of the U.S. economy, on state budget economies. And I was wondering if you could speak to sort of the fact that for many of these communities, Black communities, brown communities, working class communities, the gateway to medical care is through Medicaid, and Medicaid is in large part funded by states in addition to the federal government. And currently, almost every state in the United States has a requirement that they balance their budget every year. So what do you think we can expect to see coming up or coming down the pike when the economic bill from this pandemic comes due?
Okay. The only entity that has a financial wherewithal to pay for coverage is the federal government, because the federal government can deficit spend. They can just print money if they want. And as Will is pointing out, the states are not allowed to do that because all 49 states are required by law to balance their budget. So if we're going to have the money to have the public purse, the taxpayers pick this up, it's going to have to come through the federal government. Now, even within the Trump administration, they are responsive to political pressure to come up with money to deal with this. And certainly if we have a new administration come January, I think we're going to have to demand that that administration come up with the money to pay for health care. I do think the demand that some of the demands of the single payer movement are actually a whole lot stronger than they ever were before. Certainly we have the electorate on our side, and certainly many people who thought they had good private health insurance don't have it anymore. But also the whole idea that there's a price on a sick person, and that the price that you get for doing an elective surgery makes it very profitable to provide that, but the price that you get to take care of someone dying from respiratory failure makes them unprofitable and makes your hospital go under. I think that idea has kind of hit home to people, that the whole way we think about healthcare as having prices and having fees and having different insurance, that's a crazy way to provide healthcare. So I actually am optimistic. I think I'm much more optimistic than Professor Reed, frankly, that we're going to make a lot of progress in terms of universal coverage and increasing the government's role in paying for coverage. Will we get all the way to Medicare for all? Well, I sure hope so. I don't know that, but I think we're at a point in history where we could really make a lot of progress on that one.
Yeah, it's interesting you mentioned the role that perhaps voters who thought they had good health insurance but lost it during the pandemic might play in helping swing the tide of public opinion on Medicare for all and single payer healthcare. One of the really great questions that we got in the chat during your talk was about your comments on the financial health of that health insurance industry. And so the question is, how can health insurance companies be doing so well if they're collecting premiums from millions of fewer people than they were before the pandemic? If the economy has sort of bottomed out and everyone's lost their job, how are these companies still making money? What's keeping it alive?
Okay, they're making money because people are not using these elective surgeries that are so expensive and elective medical care. So everyone's has been afraid to go see the doctor, and certainly if you need elective surgery, you probably tried to prevent it and postpone it, and you're thinking about getting it later. I mean, even people who needed cancer surgery were initially postponing surgeries, but certainly people with less urgent or less emergent needs for medical care just postponed it, and probably some of them are never going to end up getting that surgery, So it turned out that the health insurance companies saved so much money by everybody being afraid to go in and get routine medical care that even after they paid for COVID, they were just rolling in dough and making huge profits.
So we sort of have this issue of people, paying up front and then essentially being denied the ability to access that care that ostensibly they should be able to. And I wonder as well, or the person who asked the question was also wondering as well if there's perhaps a role here that investors, maybe the reason why the health insurance stock is so high is that investors are forecasting an increase in premiums next year.
Well, in order to get the increase in premiums at each state, the insurance company has to go to the state regulatory board. Now, in some states, it's like a rubber stamp, but in many states, the insurance commissioner actually looks at the finances of the insurance company and makes a decision about the premiums. But it means that even if the costs were to go up, they could go to the commissioner and probably get a premium increase. I think part of it is that they've been able to use their cash to actually strengthen their position. So they've been doing things like rolling out money to the doctors and hospitals who are within their network, creating a strong incentive for doctors to come into their network to allow the insurance company to have greater control over them, within the network, because the insurance company is the one doling out cash to them. So I do think they will be using their all these reserves that they have to try to strengthen their position vis-a-vis doctors and hospitals, and perhaps that's what investors see as the long-term rosy outlook for the insurance industry.
Excellent, thank you. Another one of the really great questions that we got, to circle back to some of your slides on the distribution of resources between, wealthy patients, white hospitals that serve predominantly white communities, and hospitals that serve predominantly Black or Latinx communities. What kind of data do we have about the breakdown for hospitals that received funding under the pandemic stimulus measures passed by Congress? How has that been distributed between hospitals?
Okay, the initial huge chunk of money was just pushed out to hospitals based on their total revenues the previous year. So if you were a big elite hospital that brought in an extra 20% above other hospitals on a per patient day basis in terms of revenues, and you got 20% more than those other hospitals. If you were a struggling community hospital or a public hospital that was getting much lower reimbursements per patient day, then you ended up with much less money out of the original bill. The second round was supposed to correct some of those inequities and go more toward hospital areas with high rates of COVID, like New York City and Boston. And they were supposed to give a little extra money to hospitals with high Medicaid loads. However, those second and third rounds were much smaller than the first round. So today, the money has gone predominantly to the richest hospitals in the country. So the exact opposite of where it was needed the most.
Interesting. So we're going to do one more question to you before we open it back up to questions for both you and Professor Reed. So we have, let's see here. So besides spending less on public health, we also have sort of this lack of integration between hospital care, the health care that we get as individuals, and public health within our medical system. And when we think of public health, we're thinking oftentimes of government bodies, regulatory bodies, and sort of the people who choose whether or not to fund that. And as the question that we have is how do you think that we can sort of begin to address these issues, particularly thinking about the movement for Medicare for all?
Okay. Well, the first step is to recognize that this is a problem. I mean, I bet very few people on this call, other than the public health experts, knew that public health funding had come down 20% in the last decade, right? And that about 20% of the state and local health department personnel had been laid off, right? As we reduced our public health spending from more than 3% of health spending to 2.5%. So that's part of the problem. I mean, the public health people in general, I work in public health now. I worked for many years as a clinician in internal medicine, but those are usually the good guys. They're actually people trying to do their job, but it's very demoralizing when 20% of your colleagues get laid off and they don't even appoint the head political administrator in Washington is supposed to help you out, and they allow 700 positions at the CDC to go unfilled. It's very demoralizing and has made it very hard for our public health workforce to do their job. So we need a president, hopefully a new president, who commits to funding public health. We need Congress to commit to that, and we as physicians need to support that. I think part of what you see in countries like Canada is that you know, since the government's funding the entire bill for public health and medical care, they can make the decision about what's the most efficient use for those dollars. And if they decide that we need to give more money to public health and less money to, say, shoulder replacements, which by the way don't work very well, but occasionally they work, right? But they decide we need the money more in public health, they can do that. And that's what's happened in Canada. But the United States, we have a market-based system. We have neoliberalism that tells us the public sector can't do anything. It's all got to be done privately. And consequently, the money has just been going and going and going into hospitals, into for-profit insurance companies. It's been going for services that are profitable, but not necessarily that are most needed. And that just left us with going into the COVID pandemic with a substandard healthcare system and a substandard public health system, despite spending more than any other nation on earth on health.
Thank you so much. I think that's actually a terrific segue to pivot back to sort of our open Q&A session for both you and Professor Reed, you know, especially thinking about what he said about a politics of sort of like public benefit, right? And this idea that we need to conduct business in this country or governance in this country with an eye towards actually helping people. So I'll turn it back over to my co-moderator, Martha, who's going to do the question wrangling for this last part of the Q&A. Thank you again, Dr. Woolhandler.
So, hi again, everybody. I'm going to start out with a comment that was put in the Q&A by one of our attendees, and it's directed to you, Dr. Woolhandler, and it's probably somebody you know, because they say, Steffi, perhaps you and Bernie could make a series of these kinds of presentations as part of preparing for the Democratic Convention, so we can raise consciousness on these issues in time to influence the Democratic platform and maybe help to nudge Biden and his VP nominee. Is this possible? And this goes right along with another comment that says, the current nominee is not a strong proponent and is willing to compromise and compromise. Can we get this done? So that comment was for you, Steffi. So you might want to start out answering that, and then both panelists maybe talk about how we can kick a little butt at the Democratic Convention and before to get the best possible platform plank on our issue.
Okay, well, I should be clear, you know, Bernie and his staff call me from time to time with a health policy question. They do not ask me for my political strategy advice, okay? So I agree with the questioner that this would be great to have a real strong Medicare for All statement at the convention. My guess is that's going to happen, but you know, I don't have an inside track on that.
I think the intent of the person making the statement was rather for you to provide more of your data to the Bernie folks in particular, not for you necessarily to be advising on strategy. But as we know, your data over the years have been fantastic aids to moving forward. And that, okay, well, I think, is the intent of the questioner.
Okay, well, thanks for the suggestion. I think I'll send it along. Okay.
Okay, Dr. Reed, on that question about any thoughts about how we can move our piece of this platform in the coming couple of months, or the month or two? Yeah.
Well, I mean, I know that we're going to have some voices on the platform committee. I mean, I don't know. I mean, look, I think that we need to do whatever it is, or more whatever it is we've been doing, like pressing for the Jayapal Sanders bill in Congress as a short-term proviso. Like, I had a little bit of an end to the joint Biden-Sanders task forces, but I'm not sure what the state of the healthcare task force is. Like, I know we're going to have some people on the platform committee. I mean, I suspect that there'll, you know, be another fight at the platform committee meetings like there was in 2016. And maybe another fight on the convention floor. I know that the line is going to be that we have to unify and not show any dissension, because that's been all Biden's had to offer so far. So I mean, I don't know. Like, we're not in a strong position, and I mean, my will has the optimism that Steffi has. Practically, I mean, I hope she's right, and I hope I'm wrong, and she probably knows better, has a better feeling for the pulse of the national debate around healthcare. I just, my sense is just that Biden's not really prepared to give anything up. I mean, we've got to push as hard as we can to see what we can get, but yeah, that's my hunch.
I'm just seeing a comment from our old comrade, Anne Emanuel Byrne, who urges us not always to use Canada as our comparator, but rather to look at maybe some more aspirational comparators, one of which is represented by the photograph that's behind Dr. Reed, and that is Cuba.
Yep.
Now, when we do health policy, we usually talk about comparing like with like, rich systems to other rich systems, but frankly, my dears, Dr. Byrne is absolutely right. Cuba and Costa Rica have us beat by a mile.
Mm-hmm.
So I think that where we really should go from here is to have Drs. Woolhandler and Reed each give us a sense of where you see us going as a movement within a broader social movement in the next couple of months.
Well, I've just seen tremendous movement within the medical community with major medical student involvement through White Coats for Black Lives, demonstrations around the country at medical schools, in some cases committing to change the way they think about recruiting and admitting Black people and other people of color, to try to actually start to approach parity of minorities within the profession, parity with their share of the population, in ways that I have never seen that in my lifetime, you know, and I've been around a while. So the medical journals have been carrying articles and opinion pieces and data about racism, about transforming the healthcare system, about critical of employer-sponsored coverage in a way that I've never seen it in my lifetime. So certainly within the House of Medicine, if you will, we're seeing a tectonic shift in attitudes towards social change. And that is a lot our job, right? We tend to work in the healthcare system primarily in this organization. So we need to be out there leading that, pushing it, providing the ideas, working within our hospitals or departments to actually get some change, not just symbolic stuff, what my kids would call performative anti-racism. We don't need to just perform our anti-racism. We need to do our anti-racism, to actually use this moment to get some changes in the healthcare system, and particularly within the medical profession.
Dr. Reed?
Well, that sounds pretty encouraging to me. I mean, it's good to know. I mean, I've been saying lately that, you know, I'm not even 100% convinced that there's going to be an election in November, right? So I think I set the bar pretty low. I don't know. I mean, it's great to learn that these openings have occurred, right, and have been forced by the moment. And I certainly agree with Steffi that you know, our job is to take advantage of them and to pry them further open. And next couple of months, I mean, I don't know. I mean, I think the political situation overall is very fluid. I think, as I've said before, I think the moment should be ripe for propagating support for Medicare for all broadly and beyond that. I think, you know, that's the challenge that there is for us. You know, I often say that I'm a political scientist, and as a political scientist, we work best at predicting what's already happened. So I could tell you why it was necessary that Woodrow Wilson won the presidential election in 1912, but when it comes to looking down the road, we're not so successful.
Well, that's true of us as doctors too, you know. We're not so good at predicting the future either for our patients.
Right.
Okay.
So I guess, I mean, we'll see, but it depends on our efforts, partly.
Any final thoughts, comments by either of our featured speakers? I'm really good as a professor in having silences so that people who don't usually speak up will speak up. This isn't that kind of moment though.
Yeah.
So I think that what I'll do now is turn this over to my co-moderator, Will, for the next portion of our program.
Thanks again, Martha. So we'd like to end the forum by sharing a few concrete ways that you can take action to advance the cause of justice. The links that I'm going to mention in the following action items are going to be posted in the Zoom chat room, so you can find them there. If you're calling in by phone, we'll email everyone later with these links and sort of with more details, so you can find out more information and take action with us. First of all, the deaths of George Floyd, Breonna Taylor, Tony McDade, Layleen Polanco, and too many other Black people at the hands of the police have reminded us that the institution of policing is fundamentally flawed. For those of us who are healthcare workers and students whose professions are dedicated to protecting human lives and well-being, we have a particular responsibility to speak out for institutional changes aimed at ending these rampant abuses, particularly against people of color. So we urge you to call on your elected representatives to defund the NYPD and reinvest in human services, particularly for New York's Black and brown communities. You can find resources, including email templates and call scripts in the link in the chat. And again, we'll send that information to you within the next few days. Second, we invite you all to attend a virtual educational forum on Black workers and the triple pandemic of COVID-19, economic depression, and structural racism. The forum is tomorrow, June 24th, from 12 noon to 2 p.m. Eastern Time. To RSVP for the forum, again, visit the link in the chat. That link is also tinyurl.com/triple-pandemic for anyone who's on the phone listening in, and just in case we don't get the email out before tomorrow noon and you'd like to attend. Finally, if you're in New York City, we'd love to invite you to march with us in the Queer Liberation March, which is hosted by Reclaim Pride NYC. The march is going to be this Sunday, June 28th, and it's going to be stepping off from Foley Square in Manhattan at 1 p.m. We're going to have a guaranteed health and housing contingent that's going to be marching in the Queer Liberation March. So please join us. We're going to have a link to an RSVP form so you can get updates the day of. And for everyone who can't join in person, the march will be live streamed on reclaimpridanyc.org and on @QueerMarch on Facebook and Twitter. This year's march is in solidarity with Black lives and against police brutality. So join us and demand that New York City redirect funds away from the cops and towards the economic and social needs of Black communities. Again, follow the links, see the email that we'll be sending out, join us and take action to advance the cause of healthcare justice, racial justice, and economic justice. Finally, I'm very pleased to introduce Dr. Daniel Lugassi, Dr. Lugassi is an emergency medicine physician here in New York City, and he is a fellow board member of Physicians for National Health Program, New York Metro. Danny.
Great, thank you, Will, and thank you, Dr. Reed and Dr. Woolhandler. I was just asked to say a few more words about PNHP's support of the Black Lives Matter movement. As a physician, as healthcare workers, and healthcare advocates, we understand that the care of Black people extends beyond hospital walls. And while we are welcome to the discussion of racism in medicine, which we've been having for many years, has been said tonight, racism is deeply rooted in U.S. healthcare, whether it's access, segregated care, healthcare disparities, a lack of Black physicians. But I want to say first and foremost, this movement that we're supporting is about racial violence, and police murders. This is a public health emergency because the deaths from violence, regardless of a bullet or a chokehold, these are completely preventable deaths. We take an oath to care for our patients. So when Black patients are dying of a disease at higher rates than their white counterparts, we're compelled to act. I can tell you about numerous studies that show the toxic stress of Black Americans from over-policing, mental harm, physical harm. There's even studies that show communities that are over-policed and have higher rates of negative police interactions mistrust the medical system in that community. And that's on top of hundreds of years of US medicine disrespecting and defiling Black bodies and experimentation and exploitation. But I think sometimes we make a mistake in medicine. We answer feelings with facts. So for us, we're working to end white supremacy, and we support Black Lives Matter because this is about humanity. This is about restoring the trust. This is about respect and dignity of the lives of our Black patients. The lives that we've seen lost, our fathers, sons, brothers, uncles, they're pillars of their communities, and the ripple effect of their violent deaths are devastating. So at this point, if you've enjoyed our forum tonight, as I have, and have supported us, if you're new to us, we're hoping that you'll take a moment, if you can, to donate to PNHP New York Metro. I think Will's gonna put up our donation link. I mean, we're all working together to finally have a universal healthcare system that provides healthcare for all, a Medicare for all system. We're working on that in New York State with the New York Healthcare Act, and obviously across the nation with Medicare for all. Your support is vital. All of our funding comes from our donations, and we need that to keep making sure that we can offer all of these great activities and support all these great activism. So thank you everybody for joining us tonight.
So thank you all again for joining us. And Danny has highlighted the need for donations to our group, the New York Metro chapter. We have not been able to hold our usual spring fundraising gala. So keep that in mind. We really would appreciate any donations that you can conceive of making to us. I want to thank Dr. Reed and Dr. Woolhandler for their really thoughtful presentations this evening, giving us some sense of things that we might actually be working on in the next few months and then again during the next year. We do not plan to sponsor another forum during the summer, although we may co-sponsor a celebration of Medicare's 25th birthday in late July or early August. So look for that. And we look forward to seeing you in September when our students will be presenting a forum for the New York Metro chapter. All the best to you. Get out and organize. this is a really important time, I think, for us to be pushing for Medicare for all as a way of really organizing in the present context of the political landscape. Thank you, and have a good night and an active time over the next period. All the best.